Okay, palpation of the cervical and thoracic spine. When palpating, just be mindful of a few things, making sure your pressure is comfortable, you're not too pokey, make sure your nails are trimmed down nicely, and be mindful of like pulling on skin and doing like kind of a skin burn kind of a thing. So just be mindful of those things when going in this. And if you have a partner, be vocal if the person is too handsy or too pokey. It's the only way they're gonna know. Okay, so first thing here, in sitting, we're gonna look at the manubrium and sternum. So if I come here and just basically go to a nice little divot here in the cervical spine, there's a little bit of a jugular notch right here at the top of the manubrium. So manubrium's here, jugular notch here. Track down the manubrium, now it becomes the sternum. So all this here, sternum, okay, all the way down to the bottom of it being the xiphoid process there. So manubrium, sternum, okay. If I want to track laterally to feel the rib, get on the sternum here, go lateral. I should feel nice, firm, bony here. If I go a little bit inferior, it's very soft and squishy. There's the intercostal muscles. If I go a little bit lower again, firm again on the rib. So firm, soft, firm, soft. That's how you're going to be going through the ribs, making sure you're on it. So if I want to get to the costo-sternal joint where the sternum meets the cartilage, we're going to be here, track laterally off the sternum until I feel a little bit of a kind of ridging or just like a differentiation where it changes. That would be right there. So that would be my costo-sternal joint. And then I'm going to go more lateral along the cartilage until I feel, there we go, another differentiation. And then that would be the start of the rib. So then this would be my costo-chondral joint. And there's the rib, and then I'll keep tracking laterally around the rib. And then I could go inferior to the next rib. Right now I'm on rib 3, going this way, okay? So coming back up to the sternum, if I track laterally from the top of the manubrium here, I'm gonna hit another change. Right there I can feel a ridge or like a road bump, and that's gonna be where the clavicle, here's our clavicle, collarbone, comes around and articulates with the sternum. So that would be your sternoclavicular joint, right here. Track that clavicle up that way. So just inferior to the clavicle, there's going to be a space, and then inferior to that space is a firming, and that's going to be your second rib. The first rib is actually a little deeper in here, and it runs underneath here. To get to that from the anterior, we have to go inferior to the clavicle and straight to the posterior. So I push in there, that would be his first rib right under his clavicle there. For this one, we're gonna try and find the spinous processi of the cervical and thoracic spine, specifically starting at the spinous process of the cervico-thoracic junction. In order to find the cervico-thoracic junction, first let's just find the spinous processes in general. So dead middle of the spine, we're looking here at the spine. I like to think of the spinous processes as processi as the dorsal shark fin or the dorsal dolphin fin here. Sits like this. If I pinched it right there, there's our spinous processes. Processi going down there, like that. Okay. Now, the C7 spinous process is the most prominent one from the posterior. And then T1, so the cervical thoracic junction is the combination of those two joints, the C7 meeting the T1. In order to find that, little technique we do, first just pick two of them. It doesn't matter which two, but two that you think could be the C7. So I think that my left thumb is on C7 and my right thumb is on T1. What we do is we have the patient actively go into cervical extension. Go ahead and do that. Good, and then back down. Okay, and when that happens, C5 and C6 spinous processi should slide anteriorly and thus kind of disappear under your finger, or move at least. And then the C7 and T1 should stay still. So when I'm here, and then now I'm here, go ahead and do that again. Good, and then back down. So I'm feeling this one move and this one move. Come down here, go ahead again. Good, and back down. I felt this one move, but not this one. So this one would be my C7, this one would be my T1. 7, 1, because again, this one did not move when he went into cervical extension, but this one did. So here's my C7. From here, I can count superiorly. I'm on 7, and then keep your thumb or your finger on the position of the one you're counting, so that way you know you don't double count it on the way back up. So I'm on 7, 6, 5, 4, 3, 2, and 2, remember, has that bifurcated spinous process, so you'll feel the two little tips of it, depending on how much soft tissue the person has. You'll feel that. Then the next one will be C1, directly inferior to your occipital space here, inferior to your external occipital protuberance, right here, the most prominent space on the occiput. If you go inferior to that, there's your suboccipital fossa. And then straight anterior right after that will be your C1 spinous process, or spinous process where it would lie, but C1 doesn't have one, so the body right there. If we're having trouble getting into that space, put your table into a little bit of flexion. Go ahead and slide up a little bit if that bothers you there. There you go. And that'll help open this space up a little bit, so it makes it easier for me to get in here, putting them in flexion. And actually I can feel his spinous process of C2 much easier now. There we go. So a little bit of cervical flexion will help open up that space, especially for the upper cervical levels that are a little more challenging to get into. Okay. Now, if I'm coming down here, and again, I thought this was 7 and this was 1. And again, I'd have him lift his head. Go ahead and lift, patient, please. Thank you. Back down. Good. So 7 and 1, because that one moves. So 7, 1. Then, now from 1, T1, I'm going to count down here. T2. Notice they're a little bit more spaced than the cervical ones were, because these spinous processes are a little longer, and they're actually like going downward, almost like a teardrop. Okay, so 1, 2, and then 3. Now with the spinous processes, and then looking at the transverse process. So if I want to look at the transverse process of T1, okay, I'm going to go laterally. But here's the trick. With the thoracic spine, you may have heard of the rules of 3. You will need to know that, but what we're going to focus on for palpation are the rule of 1, and that is the transverse process is of the, the spinous process of the inferior level is in line with the transverse process of the superior level. So for example, if I'm on T1 right here, this spinous process here is T2's spinous process. So transverse process of T2. Spinous of T1, transverse of T2. Spinous of C7, transverse of T1. Spinous of T2, transverse of T3. T3, T4. Spinous of T3, transverse process is in line with the level inferior. Yes. So this would be transverse of T4, spinous of T4, transverse of T5. Okay? To find that facet joint now, or apophyseal joint, you're going to just find your spinous process again, which we've already found, super easy. You're going to drop just lateral to that into the laminar trough space. So I'd like to try and squeeze in between the spinous process and the erector muscle bulk here. Slide into that little space. Try and shift the erector muscles laterally if you can a little bit, and get down into that trough. That is where the facet joint's going to lie. It's going to line up with the spinous process, go lateral, push that over a little bit and straight down, and we're going to feel some firming under the thumb or your finger. It's not going to be a very distinct palpation like the spinous process is. You probably won't even feel like you're on anything. It's just going to be really affirming underneath the soft tissue when we hit that joint. Okay, so spinous process, laminar trough, try and move the muscle bulk a little bit, and straight down, that's where your facet joint is going to lie. Think about maybe finger width. I'm pushing up against the spinous process right there, finger width out. Okay. And then for the transverse process, we already did that. So now we know where the transverse process is going to lie. Again, I'm in spinous process here. Let's call this T4. I go lateral about a finger width, and there is my facet joint. I go a little bit more lateral, and there's my transverse process of, if this was T4 spinous, this would be T5's transverse process. I'm going to apply some pressure there and feel some firming underneath there. Yes, that's it. I'm on something firm. If I go a little bit up, ooh, that's a muscle. There's a spasm there. Okay. So right here, I'm on that facet, or I'm sorry, I'm on the transverse process. Now this is going to articulate with the rib. So if I walk out a little more lateral, I should find a rib, and there's the rib, and I'm going to track that around. Come back up, come down. Just like in the front, there's an enter space, and then right along the rib there. And I can even kind of just put my finger here, and I'll feel rib, space in between, rib. So I can really feel the rib there as it goes along. Like that. Okay. So this is where your costotransverse joint is going to lie, where the rib articulates with the transverse process. Okay, so there. Latissimus dorsi. These are your primary shoulder extensors. Okay, so from this position, you could have the patient lift up like so and hold it up. Let me see. Right there, they could hold that arm up. I could resist, hold here, don't let me move you. I could push down, and then we're gonna feel firming along here as it comes down off the humerus at an angle and inserts here on the thoracolumbar fascia. So there would be his lat right there, all the way there. Good. And then if we check the other side, go ahead and raise this one up. Good, and hold there. Good, there you go. You can see that really nice. Okay, so coming along here, that would be the lat. Big wing guys like this. Okay, and it's even here on the lateral side as well. You can see it from the anterior. Okay, there's our lats. Rhomboids. So these, they come from spine C7 all the way to T5, all right? And then we're gonna go obliquely, okay? There are rhomboids like so, all right? And they're gonna be going to the medial scapular border, and they're gonna be here. These guys are deep to some of the other muscles, so it's gonna be a little bit harder to feel. There we go, right there. So what I like to do is look for the fiber orientation, which I know is going this way, and then you're gonna go across the fiber orientation and see if you can elicit a little bit of a jump there. Good, so I can see there are his rhomboids, here, here. Good, rhomboids, major here, major minor, they blend together, all right? I could have the patient squeeze their shoulder blades together, there we go. And so now I can feel them right here. So there would be my rhomboids here, okay? And then while we're here and we're looking, we can see, here's our middle traps right here. And then these are our upper traps right here. Middle, and then lower traps come down like this. Try and bring your shoulders in your back pockets. There we go, there's a lower trap here. Coming like this, okay? When looking for the carotid pulse, taking the pulse, you just want to use your 2 fingers, keep your thumb out of it. So the carotid pulse is going to be right here. Good, so I can feel it pretty strong right there. You don't want to push hard enough to occlude the artery, but you definitely want to have some pressure on it so you can feel that pulse there. And then the C1 transverse process, we're going to come around to that from the posterior because it's a little tougher. Sternocleidomastoid muscle. So that's going to be coming down to the clavicle, coming off the mastoid process here. And I'll come around and show you that mastoid process, but that's that guy right here, this bony prominence. So the SCM, or sternocleidomastoid muscle, is this guy coming down here, and it's going to have its sternal attachment as well as its clavicular attachment. So if we have the patient turn this way and then lateral flex that way, there it is. We can see that muscle kicking in real nice all the way down, attaching there, coming right off of here. And if I resist, go ahead and push into my hand. Good, you can really see that kick in. So there's the sternocleidomastoid. Try it on this side. Go ahead and laterally flex this way. Good, and then hold. There it is. Good, kicks in there. Nice. So there's your sternocleidomastoid. So parotid gland, not entirely palpable, but we know it lies over this space of the mandible right here. So if there was inflammation or swelling of that gland, you might see this area being tender or puffied out, but you're not going to palpate it, just to know where it's at. The external occipital protuberance, the most bony, most prominent spot in the back of the head here. Superior nuchal line will be here, okay, right underneath that occipital protuberance, which is where those paravertebral muscles originate from. Okay. We just kind of talked about the mastoid process a little bit, but I'll come around here and you can see right under here is the mastoid process there. And here. Okay. Suboccipital fossa, this space right in here, right underneath that external occipital protuberance and under the inferior to the superior nuchal line. Cervical spinous processes we went through. Apophyseal joints, similar to the thoracic spine. For the cervical spine, you're just going to find your spinous process and drop laterally, maybe not as much as a full finger width here because it's a little bit smaller bones, and then you're going to feel that facet joint on either side. Again, the muscle bulk's in the way, so sometimes you have to come underneath it that way or push it lateral and come underneath that way. For him, his muscle's in the way, so I'm going to come laterally and then go right there, and then there would be his facet joint there, or his apophyseal joint, and there. Trapezius muscle, we can see it again here in sitting. Go ahead and shoulder shrug if you don't mind. There we go. So here we can see upper, middle, and then lower down here. So his middle are taking over a lot of it. Good, and relax. Paraspinals, those are your erector spinae, your main kind of muscles of the back. That would be these guys here running right along the spinous process, just laterally to that. So in order to kick that in, you would have the patient extend. So try and sit up tall and push back into my hand. There you go. Good. And I can feel those muscles firing right there. Another easier way would have them in prone and then have them do a Superman, and you can see that kick in a lot better. Levator scapulae. Those come off the superior angle here of the scapula, which when we get to the scapula, we'll go over that. But here's your medial angle, comes up, superior angle, and then here's the spine of the scapula. So there's the scapula. I'm going to track that. I'm along this spine, this come around. Here's the lateral border, the medial border. So right here at this angle, that's going to be the origin for the levator muscle. So right here, I know levator is going like this. So I'm going to go cross friction against the fibers, perpendicular, to try and feel that guy kick in. So right there I can feel it. And then sometimes you'll even see a little trigger or twitch response shoot right up there. But here's levator here, and I would track it like this. Remember, it's deep to the traps, so it's going to be a little tougher. You have to go through the trap muscle to get to it, but that's it there. The way I differentiate it is trap muscles are going this way, levator's going this way. So if I go across like that, there's the trap. I can actually pull on the upper trap right there and pinch it pretty good. Levator is going to be more this guy. And I could have him also shrug the shoulders a little bit. Good, and then tip your head back a little bit. There we go, and then hold there. Good, and that was, I could fire that and kick that in. Good. First rib is a bit tough. It's actually quite tough. What we're gonna do for that is you're gonna come through this space here. So we have our upper trap, and I can pinch it. There's my upper trap right there. Then the next muscle coming anteriorly is gonna be the posterior scalene. And that's this guy right here. So go ahead and tip your left shoulder towards your left ear, your left ear towards your left shoulder. There we go. So that muscle right here, that guy, that's his posterior scalene. Kicking out pretty good there. Okay, pretty tight. Come on back to the middle. Do that one more time. There we go. So we can see his posterior scalene. There's his middle scalene. And then his anterior scalene here, just behind the SCM. So anterior, middle, posterior. Okay. Sorry, this one's posterior scalene. This one's middle scalene. This one's anterior scalene. Middle. Posterior is right there. Different than the trap there. Okay. So now that I know where the scalenes are, go ahead and take a break. I'm going to try and go anterior to the trap, but posterior to the middle scalene if I can. Maybe even in between the middle and posterior scalene. I'm gonna go straight inferior. Imagine my finger like a C is the first rib sitting kind of like so, but underneath my hand and maybe a little closer, so like that. So it's basically this pathway. Okay, so from there, I want to try and get down into here and put pressure on something firm. Go ahead and tip your head to the right a little bit. There we go. So that way it takes some slack off. I'm going to go straight inferior. Right. Where is it? Right there. So for him, it's right there. Real firm. It's tough because there's a lot of soft tissue. The brachial plexus is here. It's very tender. Sometimes having them lying in supine is going to make it easier because then you take the paravertebral muscles out of the picture. So first rib going straight down through here. Okay. Next, the transverse process of C1. Pretty challenging to do, but what we can do here is show you process of C1. Think about going to your mastoid process right there, and you're going to go slightly inferior, okay, and then you're going to go directly medial from there. So inferior, maybe even slightly posterior, so you can get behind the sternocleidomastoid bulk, and then right there, go straight towards the medial, straight towards his spinous process, and then it's going to be this firm dude in there, right there. So for him, it's right there. It's very wide. You can see it's pretty wide out here, and it's very high. So it's a really wide pinch, and I can feel him right there. Okay. Think about mastoid process. That's going to be a good jumping off point for you. And then straight in there. Okay. Greater occipital nerve coming up like so. If you're back here, you can kind of practice on yourself, play around, kind of just go cross friction, and you'll feel a little bit of a twang. You feel a little, does that feel a little nervy to you?
No.
No? Okay. So we're gonna find a, where is it? How's, no, not that. How about that one?
Yeah.
There we go. So now we're feeling some nervy tingles. So it's in this space here in between the sternocleidomastoid and the upper trap. You're gonna feel it right off the back of this corner, and it comes up around like this, and it's usually pretty sensitive. So practice on yourself, find it, and then you can practice on someone else.